Hello everyone. Welcome to 2-Minute MRCP. Today, we will quickly review Antiphospholipid Syndrome. Antiphospholipid Syndrome, or APS, is an acquired autoimmune disorder that causes an increased tendency for both venous and arterial thrombosis. It is also associated with recurrent miscarriages and thrombocytopenia. APS may occur as a primary condition or secondary to another disease, most commonly systemic lupus erythematosus, or SLE. In fact, around 30% of patients with SLE have positive antiphospholipid antibodies. Now for a very important MRCP exam point. Antiphospholipid syndrome causes a prolonged APTT, despite the patient being prone to clotting. This is known as the Lupus anticoagulant paradox. The Lupus anticoagulant antibody interferes with phospholipid-dependent coagulation tests in the laboratory, causing a prolonged APTT, but inside the body it actually promotes thrombosis. Other associations include autoimmune diseases, lymphoproliferative disorders, and rarely, phenothiazine use. Clinical features include venous or arterial thrombosis, recurrent miscarriages, levator reticularis. Patients may also develop preeclampsia or pulmonary hypertension. Investigations include antiphospholipid antibodies. The three key antibodies are Lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. Laboratory findings often show thrombocytopenia and prolonged APTT. Now let's move to diagnostic criteria. For the diagnosis of APS, a patient must meet at least one clinical criterion and at least one laboratory criterion. Let's start with the clinical criteria. The first clinical criterion is thrombosis. This means the patient has had at least one episode of arterial thrombosis, venous thrombosis, or small vessel thrombosis. Importantly, the thrombosis must be confirmed objectively, either by imaging studies or by histopathological examination. The second clinical criterion relates to pregnancy morbidity. This includes 3 or more consecutive unexplained miscarriages before 10 weeks of gestation. Alternatively, it includes 1 or more unexplained fetal deaths at or beyond 10 weeks of gestation. Another qualifying feature is a preterm birth before 34 weeks due to placental insufficiency or severe placental disease. Now let's move on to the laboratory criteria. The laboratory abnormality must be present on at least 2 separate occasions, at least 12 weeks apart. This requirement is important because transient positivity can occur during infections or other temporary conditions. There are 3 key antibodies tested in APS. The first is the Lupus anticoagulant. The second is the anticardiolipin antibody. The third is the anti-beta-2 glycoprotein I antibody. Management focuses on preventing thrombosis. Low-dose aspirin may be used for primary prevention in selected patients. Following a thrombotic event, lifelong warfarin is usually required, with a target INR of 2 to 3. For recurrent events, a higher INR target of 3 to 4 or addition of aspirin may be considered. Arterial thrombosis should be treated with lifelong warfarin with target 2 Indian rupees to 3. During pregnancy, the recommended treatment is low-dose aspirin plus low molecular weight heparin. Direct oral anticoagulants are generally not recommended in high-risk APS, especially in triple-positive patients. And that's all about antiphospholipid syndrome. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.